A new heart won't save a patient if their immune system just violently rejects it. Or if the surrounding blood vessels are, simply too weak to support the new organ.
Right, yeah. You can find the most perfect donor heart in the world, drop it into the chest cavity, and just, expect a miracle. But medicine is way more brutal than that.
Exactly. The systemic health surrounding that new organ really dictates whether the patient lives or dies. And today, we were doing a deep dive into South Africa's proposed national health insurance, the NHI, which, looking at the source material, feels exactly like a national organ transplant.
It really does.
And right now, the left thinks it's this, miraculous cure for inequality,
Hmm.
while the right thinks it's going to trigger, well, a fatal systemic rejection.
Yeah, and I think it's important to state right up front that our mission today isn't to take a side in that political fight. We're really just here to look closely at the blood work.
Right, just the facts.
Exactly, because the sources provide a touch on some incredibly sensitive debates, government taxations, social equity, the raw capability of the state itself. So we are just here to impartially break down the mechanics of this transplant.
Just laying it all out for you.
Right. We want you, the listener, to really understand the foundational facts, the left-wing arguments for moral equity, and the right-wing arguments concerning economic collapse.
Yeah.
And we're doing this without any endorsement from us. We are just analyzing the architecture of the policy, and the environment it has to survive in.
Okay, let's unpack this. Let's get straight into that architecture. Because if I am looking at this blueprint, my initial assumption as a patient is that the plumbing of the medical system basically stays the same. I just change who I bill.
Right, the day-to-day routine.
Yeah, so say I wake up on a Tuesday and my knee is absolutely throbbing. I know a great orthopedic specialist across town. Under the current private system, I just call her office, make an appointment, and my private medical aid pays for it.
Yeah.
Under the NHI, do I just walk into that same specialist's office and bill the central government fund instead?
No, that is a huge misconception. That assumes the foundational structure of how you access medicine remains intact, but the NHI fundamentally tears up that plumbing.
Oh, really?
Yeah. You wouldn't be allowed to go straight to that specialist at all. The NHI operates on a strict gatekeeping system.
Gatekeeping.
Exactly. So to manage costs and patient flow, the system requires you to first visit an accredited primary care provider. Think of like a local government clinic or a contracted general practitioner.
Okay.
They are the gatekeepers. They assess your knee. And only if they medically determine that you cannot be treated at the primary level do they, unlock the gate and refer you up the chain to a specialist or a hospital.
Well, wait, how does a bottleneck not immediately happen there?
Well, that's the big question.
Right, because if you have tens of thousands of patients suddenly entering the system and like a limited number of local clinics acting as the gatekeepers, doesn't the wait to even get that referral take weeks or maybe even months?
Yeah, and that is the exact mechanical vulnerability the critics point to. I mean, gatekeeping is standard practice in a lot of European universal healthcare models, but it relies entirely on a massive, highly efficient primary care network.
Which you need up and running first.
Exactly. If the local clinic is understaffed or lacks the diagnostic equipment to even figure out what is wrong with your knee, you just get stuck in a holding pattern. The state pays for the pathway, but the pathway itself can become completely gridlocked.
Wow. And what happens to my private medical aid in this scenario? I mean, I pay a premium every month specifically so I don't get stuck in those bottlenecks. If the NHI passes, do those private insurance companies just become illegal?
Well, they don't vanish overnight, but their legal purpose is drastically restricted. The notes outline that private medical schemes will be limited to providing what is called top-up cover.
Top-up cover, meaning what exactly?
It's a crucial legal mechanism. It basically means private insurance can only cover services that the NHI explicitly does not cover.
Oh, I see.
Yeah. So if the central NHI fund decides that basic orthopedic knee surgery is part of the universal package, your private medical aid is legally barred from covering it. They literally cannot compete with the state on core services.
Wait, but that destroys the entire business model of private insurance.
Yep.
Because they rely on having a massive pool of, healthy people paying premiums to cover the expensive procedures of the sick. If they can only insure luxury or highly specialized fringe procedures, their customer base just evaporates.
Which is exactly why the private sector is fighting this so fiercely right now. The NHI is designed to consolidate all of that purchasing power and administration into one single entity, the Central NHI Fund.
And where does the money for that fund come from?
Taxes.
Yeah.
The sources suggest things like higher income taxes, new payroll taxes, or just reallocating existing health budgets. Then it uses that one central pot to pay both public and private healthcare providers, but only based on pricing structures dictated by the state.
So the system only flows if the paperwork flows. The state has to accredit thousands of doctors, manage millions of referrals, and process payments without delays, or the clinics just shut down.
That's the logistical reality, yeah.
I mean, rebuilding the entire machine of a nation's healthcare seems like an absurd logistical mountain to climb.
Yeah.
Unless there is a massive upside, why attempt a policy that requires this much administrative heavy lifting?
Well, you really cannot look at this blueprint without understanding the deep moral imperative driving it. I mean, South Africa operates on a stark two-tier reality.
Right.
The country has a private healthcare sector that genuinely rivals anything in the West. We're talking world-class facilities, cutting-edge technology, top-tier specialists. But it only serves the minority of the population who can actually afford those really expensive private medical aid premiums.
While the vast majority, the people who actually build the country and work in the shops and factories, they have to rely on a heavily overburdened public system.
Exactly. The public sector handles the overwhelming majority of the country's massive disease burden, but it is notoriously under-resourced and understaffed.
It's a huge gap.
It is. And the disparity isn't just inconvenient, it literally dictates life expectancy based entirely on your wallet. So the left-wing argument, and really the driving force of the NHI, is that this level of inequality is a historical and moral failure.
And they want to fix it structurally.
Yes. To fix it, the policy relies on a mechanism called risk pooling.
Okay, risk pooling. If I understand the mechanics of insurance, that's essentially an enforced cross-subsidy, right?
Yeah, that's a really good way to look at it. In the current fragmented system, the wealthy and relatively healthy pool their money together in private schemes. They insulate themselves.
Leaving the public sector behind.
Right. The sick and the poor are left to rely on a strained public purse. But under the NHI, the state shatters those private silos. Everyone in the country is forced into a single national pool.
So everyone chips in together.
Exactly. The young subsidize the old, the healthy subsidize the sick, and critically, the wealthy subsidize the poor. By spreading that financial burden across the entire tax base, the goal is to drastically raise the floor of public health outcomes.
Here's where it gets really interesting, though, because there is also a brutal economic angle to this single-buyer model that changes everything.
Oh, absolutely.
Looking at the notes, it's not just about sharing the costs, right? It's about forcing the costs down. If the South African government becomes the sole unified purchaser of healthcare for over 60 million people, they wield something far more powerful than just a bulk discount.
You're talking about monopsony power.
Right. It's not just buying in bulk like a warehouse club. It's a structural weapon. If you are the only buyer in the entire market, you don't just negotiate the price of a hospital bed or like a box of antibiotics. You dictate the price ceiling.
You set the rules.
Exactly. You walk into a massive multinational pharmaceutical company and say, well, we will pay X amount for your insulin. And if you don't agree, you don't sell a single vial in this country because we are the only customer.
And that is the strongest economic argument for the NHI, right there. Monopsony of power forces private providers, pharmaceutical companies, and medical device manufacturers to either accept government prices or exit the market entirely.
Which is huge leverage.
It is. If managed correctly, the state can theoretically crush the wildly inflated costs of private healthcare. They can standardize the cost of an MRI or a blood test nationwide.
And the sources show this extends to preventative care, too, which is where the gatekeeping system actually makes a lot of economic sense.
Yes, that's the long-term financial play. By forcing patients to enter through primary care clinics, the system is structurally designed to catch illnesses early.
Right, before they get expensive.
Exactly. If a local clinic effectively manages a patient's hypertension with cheap daily medication, they prevent the catastrophic financial burden of treating that patient for a severe stroke in an ICU 5 years later. So a heavy investment in primary care theoretically pays for itself by reducing long-term systemic emergencies.
Okay, so monopsony market control and robust preventative care. That sounds brilliant in theory. You catch disease early, you force prices down, you treat everyone equally.
On paper, it's great.
But to wield monopsony power, you need a highly efficient, unified purchasing department. To manage 50 million patients, you need flawless logistics. And looking at the history detailed in these sources, well, Well, the South African state seems to possess the exact opposite of that capability.
Yeah, and this is the pivot point of the debate. This is exactly where the right-wing economic arguments and the practical fears of the public collide with the moral blueprint.
So let's talk about the blood work of this patient receiving the transplant. The immediate glaring vulnerability is cost. The briefing document explicitly states there is no clear, credible answer yet on the total price tag of the NHI,
One.
or the exact mathematical impact on the taxpayer. South Africa currently suffers from severe budget deficits, massive national debt, and a shrinking tax base.
It's a very tight fiscal environment.
Right. So if I am a middle-class listener who is already squeezed by income tax, a 15% value-added tax,
Yep.
and heavy fuel levies, aren't I just going to pay more taxes while simultaneously losing the benefits of the private cover I was paying for?
The economic anxiety there is completely validated by the fiscal data. Implementing a universal system in a high-growth economy is difficult enough.
Yeah.
Implementing one in a stagnant economy with a high unemployment rate, that is a colossal financial risk.
Yeah, it's terrifying for people.
But the taxation isn't even the primary fear outlined in the text. The absolute flashing red light for the public and the critics is the risk of catastrophic corruption.
Because you are centralizing hundreds of billions of rand into one single target.
Precisely. You are creating the ultimate honeypot.
Wow.
The notes specifically point to the ghosts of past projects. Major state-owned enterprises like Eskom, the National Power Utility, Transnet, the Freight Rail Network, and South African Airways.
They've all had massive issues.
Right. These entities have notoriously collapsed under the weight of severe governance failures, mismanagement, and outright state capture. So the public looks at the NHI fund and sees the exact same centralized structure that allowed those other entities to be looted.
And we need to be clear about how that corruption actually breaks the medical mechanism on the ground. It's not just some abstract accounting error in a boardroom somewhere.
Yeah, it has real victims.
State capture in a central fund usually operates through tender inflation and middlemen. So if a central procurement office in the capital awards a massive contract for basic medical bandages to a politically connected shell company at like 10 times the actual cost,
Yeah.
the budget runs dry.
Yeah.
Which means the rural clinic waiting for those bandages doesn't get them. The doctors have to turn patients away, the gatekeeping bottleneck gets worse, and the entire system cascades into failure.
That is the systemic rejection of the transplant we were talking about. If the procurement process is infected with patronage, it doesn't matter how noble the universal access goal is. Life-saving equipment simply won't reach the operating rooms.
It just breaks down.
And that leads directly to the next major vulnerability highlighted in the text, which is the global liquidity of medical professionals.
The brain drain.
Exactly.
Because if I'm a highly skilled surgeon and the government monopsony forces my rates down to a fraction of what I used to make, while the hospitals are simultaneously overflowing because those primary care bottlenecks have failed, why would I endure that?
Well, you wouldn't have to. The reality of modern medicine is that medical certifications are globally standardized. Doctors, specialists, and skilled nurses are highly liquid assets.
They go anywhere.
Yeah, a South African-trained doctor is fiercely prized in London, Perth, or Toronto. If the working conditions deteriorate, or if the central fund fails to pay them on time due to administrative incompetence, they will simply leave.
They pack up their skills and emigrate, which completely undermines the whole risk-pooling concept, doesn't it?
It does.
You can pool all the money in the country, but if the actual surgeons and pediatricians leave, you just have a beautifully funded waiting room with no one to treat the patients. You have the blueprint, but no builders.
A mass exodus of talent is the doomsday scenario for the NHI. The critics argue that by aggressively targeting the private sector, the government risks destroying the very infrastructure and talent pool it needs to leverage for the universal system to work.
So what does this all mean? The discourse seems completely polarized. The left presents this utopian cure where poverty no longer dictates health, and the right warns of an apocalyptic systemic collapse where the country is left without doctors or medicine.
It's very extreme on both sides.
But analyzing this briefing document, the truth doesn't seem to sit at either of those extremes. We need to separate the mechanical reality from the political panic.
Yeah, the sources categorize these fears quite clearly, running a necessary reality check on the public debate. Let's start with the absolutely valid concerns.
Okay, what's valid?
As we've detailed, the risk of procurement corruption is statistically and historically valid. The financial sustainability, like how this is funded without breaking an already narrow tax base, remains a massive unresolved equation. And the sheer lack of state capacity to manage a transition of the scale is a very valid red flag.
Okay, those are the structural threats. What falls into the debatable category?
The debatable concerns are those sweeping absolute statements. For instance, the fear that private healthcare will just collapse and vanish overnight.
That won't happen.
The notes suggest this is highly unlikely. The private sector in South Africa is deeply entrenched and fiercely litigious. It is far more probable that private hospitals won't board up their windows. Rather, they will enter a prolonged period of legal battles. They'll slowly adapt their business models, find regulatory loopholes, and shift to accommodate the new top-up cover laws.
So it's not a sudden cliff. It's more like a slow erosion or a bumpy transition. What about the fear that you'll simply never be able to see a specialist again?
Also debatable. It assumes the gatekeeping system fails 100% of the time. The reality is that the queue for specialists will likely become a complex, highly regulated negotiation of resources.
Meaning it'll vary.
Yeah. In well-managed districts, you will see a specialist.
Mm.
In poorly managed districts, you might wait months. It will be inconsistent rather than uniformly broken. Which brings us to the overblown fears.
Okay.
The idea of an immediate apocalyptic system failure the exact moment the NHI bill is enacted is largely fiction. Large-scale policy shifts rarely result in instant explosions. They result in friction.
Friction. That brings us to a concept from the text that I think fundamentally defines this entire situation, the messy middle.
Yes, the messy middle.
It's vital to understand that the messy middle isn't just a compromise between two political viewpoints. It's an active economic state.
Yeah.
South Africa rarely achieves absolute utopia, but it also repeatedly avoids total collapse.
That's a great point.
So the likely reality of the NHI is that it will operate right in that frustrating grinding center. It will be a parallel existence of partially functioning state systems, legally contested private sector adaptations, and just a constant bumpy reshaping of how medicine is practiced daily.
And if we connect this to the bigger picture, understanding that the future is likely, this messy middle forces us to confront the philosophical core of the source material. It brings us to the ultimate uncomfortable truth of this policy.
Which is what?
The dilemma of action versus capacity. The uncomfortable truth is twofold. First, South Africa absolutely cannot sustain the status quo.
Right, the inequality is too high.
Exactly. Having the vast majority of your population relying on an overburdened, underfunded system, while a tiny fraction enjoys luxury care, is socially, morally, and economically untenable. The inequality is a powder keg. Reform is not optional. It is a necessity for national stability. But the second part of the truth is that the current state apparatus has not demonstrated the institutional capacity or the ethical discipline to cleanly manage a centralized project of this magnitude.
So it's a bind.
Yes. Therefore, the actual debate happening in the country isn't a theoretical argument about whether healthcare is a human right. Almost everyone agrees it is. The real debate is entirely about trust.
Trust in the government.
Can this specific massive reform managed by this specific government in this specific economic climate be trusted with the lives of the population?
It's a violent collision between a deep moral necessity to help the poor and a deep institutional mistrust born from years of government corruption. You know, you have to rebuild the hospital, but you just don't trust the contractor with the budget.
That is the exact tension. To summarize the core findings from the stack of research today, the NHI is a fundamentally appealing moral concept, attempting to correct massive historical and economic injustice through risk pooling and state purchasing power.
The goals are good.
Yes. However, its ultimate success won't rely on how elegant the policy looks on paper. It relies entirely on execution, ruthless administrative accountability, and the political will to arrest anyone who tries to steal from the fund.
And if they can't do that?
If those practical, on-the-ground elements fail, the NHI will not cure the inequality. It will simply centralize the existing public failures and destroy the functioning private sector in the process.
A perfect donor heart means absolutely nothing if the body's immune system attacks it the moment the chest is closed. Thank you for joining us on this deep dive into one of the most complex policy shifts in the world right now.
It's definitely a lot to process.
It really is. Think about your own healthcare for a moment. If your government suddenly passed a law tomorrow becoming the sole purchaser of your medicine, dictating the prices and controlling the queues, would your costs drop or would the pharmacy shelves go empty? The South African experiment is going to test that economic theory in real time.
We'll all be watching.
But as we leave you today, I want to build on that very real fear of a brain drain we discussed earlier.
Yeah.
If the ultimate survival of this national transplant relies entirely on keeping brilliant surgeons, nurses, and specialists from packing their bags for London or Toronto, how do you design a policy that doesn't just manage the patients, but actively persuades the best doctors in the world that navigating a highly regulated, frustrating, messy middle is exactly where they want to build their life's work?
That's the real challenge.
Because if you can't convince the doctors to stay, the blueprint doesn't matter. Something to think about. Until next time.